Welcome back to Tales from the Lab, a veterinary podcast. I'm Dr. Brad Ryan, Senior Professional Services Veterinarian at Antech Diagnostics.
And I'm Dr. Holly Brown, a clinical pathologist and Chief Veterinary Educator at Antech. Together, we'll be discussing real patients and bring in expert guests to offer deeper insights into the laboratory diagnostics used to solve interesting and challenging cases.
Tales from the Lab is a production of Antech Diagnostics. The intent of this podcast is to provide education and guidance with the understanding that any diagnostic testing and treatment decisions are ultimately at the discretion of the attending veterinarian within the established veterinarian-patient-client relationship.
And today we have a really common case, I think, that kind of illustrates those situations where the data isn't screaming at you about what's wrong, but clearly something is not right with your patient. And we have to do a little bit of a deeper dive on why that might happen. So let's just dive into the case, Holly. Today we're going to meet Blondie. Blondie is an 8-month-old spayed lab mix, and she presents with a 2-day history of vomiting and suspected fabric ingestion. So she's already been treated with antiemetics and sub-Q fluids, but the vomiting has persisted here. So on exam, we're appreciating that Blondie is quite lethargic. Her mucous membranes are tacky, and she's quite tense on abdominal palpation. So before we move into the lab data, I just wanted to sort of throw this back to Holly, because as a clinical pathologist, you're quite familiar with these situations. So before we even get into those diagnostics, can you tell us more about the history that this particular owner shared on this case, and what were the greatest concerns that they had for Blondie at the hospital?
Yeah, thanks, Brad. So just to give a little more color to the situation. So Blondie is owned by a young single male professional. He works from home. She gets delivered they have some subscription plan to get new toys, new treats delivered, maybe monthly, I don't know, at a regular interval. So leading up to this presentation, she had one of those new boxes delivered. She had had some new toys to play with, some new treats to eat. And the owner was particularly concerned because after a virtual meeting, when he went to check on her, she had torn up one of the fabric toys and some pieces of the fabric appeared to be missing. So this is the first health issue or health scare he had had with Blondie. He was very concerned about this possible ingestion, although he couldn't say how much. He was also concerned, at the time she was still feeling bright, but he was concerned at what this could mean for her health and what it would mean for his wallet. Was also concerning, right? Knowing how much veterinary office visits cost just to get a consultation, not to mention diagnostics or even intervention or surgery if it ever led to that. So he goes to his first appointment when a couple of days after this possible ingestion, when she had some vomiting, and she at the time still felt bright. And she was non-painful in palpation. She was non-febrile. And he elected, together with that veterinarian's guidance, of just doing, maybe she just had a simple gastritis, right? She had also had some new treats as well. Maybe some of the material that she had ingested was moving through the GI tract just fine. Or maybe he had even miscalculated how much fabric was missing, right? He wasn't that confident, but he was growing increasingly concerned. So they did treat with antiemetics and the fluids. And so then when she vomits through that, now his concern level is very high. And he can think back to 4 days previously when she had ingested this fabric. And watching her clinically decline emotionally has him really entwined in her case as well, right? So he's very sad to see her now depressed and lethargic. She's normally a very active 8-month-old puppy. So it's a dramatic clinical picture change, right, that has him coming to our hospital on emergency on a Saturday afternoon. And certainly the clinician seeing the case is concerned, right? She is now tense on abdominal palpation, a little reactive, which is not necessarily pain, but certainly concerning for pain or inflammation. Her dehydration, she was clinical for. And again, that vomiting through the antiemetic has everyone really concerned. So dad's first question from the get-go is she going to need surgery, right? He's asking that really early on and really hoping not. So that's where we set up this appointment.
Great. And so when we look at the CBC, let's start there, because I think that's the interesting jumping off point for us, because that CBC is essentially normal, right? The erythrogram and thrombogram within normal limits. And obviously, I think this is where most clinicians would get tripped up, because how do you interpret this normal CBC in a patient that clearly isn't normal typically, right? And so, Holly,
Yes.
I'm curious what you think about this, and what does that normal urethrogram and thrombogram rule out at this point, if anything, and what does it not rule out?
Yeah, and I'll first touch on I sort of squirm a little bit when I hear normal,
Okay.
right? Because right. And but I think you're exactly right. I mean, I think it's exactly what a clinician's thinking, right? When all the values are falling within the reference interval, right? So they say it's all normal. And why it really concerns me if we ever elect to only look at abnormal values when we're looking at lab work, right?
Yeah.
Because you're selecting against what might be abnormal for that particular patient and not giving yourself that visual into what could be going on in those insights. And so I do love when we look at lab data and it doesn't just report the numerical values, but it looks at those visual reference intervals. So you can see where your patient's data point lies relative to that pretty wide reference interval, right? Because it will help you detect trends if things are the results are at the very low end of that reference interval or high end of the reference interval. There's actually a really good chance that those are abnormal for your patient, right? Very few of the healthy patients had values at those extremes, right? So I think that looking for patterns is really important. And through the erythrogram, it's tricky, right? So as we looked at her data, her red cell mass was at the higher end of the reference interval. We also know she's clinically dehydrated, right? We also know that she's been vomiting, and so volume depleted in that sense. And so this could be masking an anemia, right? We don't actually know if this is truly normal for her, right? These values. And similarly, I think, well, in the thrombogram, I would say having the platelet values fall within the reference interval is it takes some problems off the list. I think it is unlikely she has active tick-borne infection, for instance. I think that reliably creates a thrombocytopenia in most patients who are presenting with acute clinical illness from infection. Other than that, I'm not so sure that the platelet count being within the reference interval gives me any additional guidance on Dad's question, which is, does she need surgery or not to
Right.
get this fabric out?
Yeah. So from there, we look at the leukogram, and clearly I'm thinking about inflammation, especially with that history and that tense abdomen. But when we look at the leukogram, we don't see that classic inflammatory leukogram, right? But we do see the lymphocytes and the eosinophils are at that low end of normal, suggesting that we may have a stress response here. So I'm curious if we could sort of walk through what a stress leukogram looks like again, and why that's not here potentially, and why we do see that lymphopenia and eosinopenia here in Blondie.
Yeah, and I these are two of my favorite topics to talk about, right? How we recognize inflammation and how the leukogram can help us recognize a sick patient. So let's start first with that stress response, because sometimes even in patients with known inflammatory disease, the first things that will flag high or low in that CBC might be the lymphocytes and eosinophils that flag low. That might be our first indicator that this is a sick patient. So what happens is, in the face of illness, right, when there's significant systemic illness, the patient's adrenal glands are going to secrete more cortisol, sort of make them more robust in the face of that clinical disease. And in response to those increased cortisol levels, the lymphocytes are going to redistribute into the lymphoid tissues. So there's less in circulation when we perform phlebotomy, and we get less eosinophils in circulation as well. And so when we recognize the pattern, and they don't always flag low, as in Blondie's case, they're at the low end of the reference interval. But that pattern of both of those values, the lymphocytes and the eosinophils, at the low end of the reference interval tells us her cortisol levels are increased, right? She doesn't have known glucocorticoid administration. She's clearly not cushingoid at 8 months of age, right? So this is her own body's endogenous production of cortisol in response to clinical disease. And it's a really sensitive test of a sick patient, right? Is recognizing that stress response. Conversely, and equally as importantly, would be in a known very sick patient, the lack of decreased lymphocytes and eosinophils. If they're at the high end of the reference interval or increase, might be how we recognize an Addisonian patient, right? That could be critical in that sense. So I do think recognizing a stress response as a lymphopenia and eosinopenia, or trending at the low end of the reference interval, is an important sick patient test, as it is in Blondie's case, where they were able to report back to dad, I realize these values fall within the reference interval, but here are some of my concerns. I appreciate the erythrocytosis, or getting, the high end of the reference interval for the red cell mass. I do think that supports this clinical dehydration. As we look in her leukogram, I am concerned at these lymphocytes and eosinophils at the low end of the reference interval, because that suggests to me that her body is withstanding some systemic illness. I do think this may be more than a gastritis for that reason. And then you ask about the inflammation, right? And so, we are taught in school, everyone is, right, that an inflammatory leukogram is characterized by a leukocytosis and a neutrophilia. And in our most intense inflammatory cases, the acute inflammatory cases that sometimes can be the most critical, right, we don't commonly see. It's actually more uncommon to see a classic inflammatory leukogram. And that's really befuddling, I think, right? When we're taught that, but we don't see it when we get out into practice, when our interpretation, this is a veterinarian working alone on a Saturday afternoon, right, trying to make a critical decision on if this patient needs to go to surgery. And now they're like, well, I was taught in school, right, that I'm going to recognize inflammation in the leukogram by those changes. And I don't see that here. And yet we have a patient who appears painful in the abdomen, who I think has inflammatory disease. Why is it not reflecting here? And that's just going to be because when we are sampling these blood cells, right, these leukocytes, we are capturing a moment in time, right? So it's always, their concentration of circulation is always going to be a reflection of the tissue demand and the bone marrow's ability to meet that demand, right? And it's very, very dynamic, right, depending on either one of those conditions being affected. And in a case where, in Blondie's case, where we suspect that we have some GI inflammation given her clinical signs, it may be that the acute demand for neutrophils, right, in the tissues, or even in the abdomen, if she had like a septic abdomen, is greater than the bone marrow's ability to meet the demand at the time, right? And so we are getting a shift of the cells from the bone marrow through circulation into the tissues. It keeps the concentrations within the reference interval, but not because she doesn't have intense inflammatory disease.
So, Holly, one thing that you have taught me, I wish every veterinarian in North America had the benefit of attending one of your lectures on scattergrams or dot plots with the element HT5, which is fortunately what Blondie's CBC was run on. And of course, I've learned from you, obviously, when we see within normal limits across the board in a sick patient, I want to go straight to that dot plot, because there's so much information that we gain from the dot plot that I think a lot of the veterinary profession is still catching up to. So let's just dive into it. And obviously we have to kind of think about this because not everybody is going to be seeing this dot plot. So let's just describe what's on that X and Y axis and where we find the hidden details for these cases so often.
Yeah, great. So for perspective, I think that many of our veterinarians and our veterinary technicians are used to interpreting a CBC on numbers alone, right? That's what the vast majority of clinicians and veterinary teams are using throughout the world. And yet there's such advanced technology in these analyzers that they are taking advantage of information that they are gleaning from the cells, right, through this advanced technology, and showing it to us in a different way, in a graphical depiction of the cells, where we get to see more than just the numbers, but we get a look into the cell morphology. So it's an automated look at cell morphology that looks at tens of thousands of cells and can be more sensitive than even a clinical pathologist at the microscope, right, and recognizing abnormalities and trends based on the sheer numbers and the objectivity of it. And so, specifically on Blondie's case on our HT5, we're focusing on the white cell differential as shown through that scatter plot or dot plot, right? So we have this scatter plot, scattergram, dot plot, any of those are appropriate terms to use, where we have individual dots on the scattergram that represent cells that were analyzed by a flow cytometer within that analyzer. And based on parameters, in this case, you're talking about the different axes that help us plot this graph. On the y-axis, we're looking at cell size. And on the x-axis, it's looking at the complexity of the cell, often most influenced by granularity that we would see like in eosinophils or basophils. And so then every cell that's analyzed by that flow cytometer will then have coordinates of scattered light that are captured at different angles to reflect the size and the complexity of the cell. So we get those two coordinates, which means we can graph it here on this differential scattergram. And it shows tens of thousands of events of these individual cells. And so in a sick patient, where you're seeing normal numerical data, I would challenge you to see a normal scattergram, because I bet that's where you will see significant changes, as we do here, because we actually know we have support that she has inflammatory disease. We don't see it in the whole numbers, but do we see a morphology change? And indeed, we do in this case. And what's most useful for our listeners when they are starting to look at these scattergrams is to have a normal for comparison. So taking a pre-anesthetic lab work from a healthy young dog or cat, you want a species-specific one, and then compare it to your sick patient ones and start to look, it's pattern matching, right? So start to look for changes in the patterns, get a tolerance for normal, because not every patient is exactly the same. A tolerance for normal, and then recognizing in sick patients where you have the most distinguishing differences in those patterns. And in Blondie's case, it's looking at that neutrophil cloud. So those who have the HT5 will know that there's a large turquoise cloud, and that's your neutrophils, which is generally going to be the largest number of dots along the leukocyte in the highest concentration, right, in a differential. And in her case, the neutrophil cloud is not positioned as it is in a healthy dog comparison. It actually is much taller on that y-axis. And so I told you on the y-axis, it tells us about cell size. So we have a significant population of these neutrophils that are larger in size. And that is key, right? Because when we're trying to recognize inflammation, as I said, a story I often tell and trying to understand these numbers and this morphology change is taking a case of acute aspiration pneumonia, right? You've probably heard me describe this before, but if we were to check, I'll use my own dog, her blood before she eats and aspirates, let's say her total neutrophil count is 10,000 neutrophils, mature segmented neutrophils per microliter. Then she eats and she aspirates, and then it doesn't take long before the inflammatory cytokines from the lungs are going to be calling out for neutrophils to come fight this infection, right? We now have tons of mixed bacteria and debris in the lungs. And so those 10,000 mature neutrophils are going to move fairly quickly from the circulation, right, to the tissue, and they're lost from circulation. And so there'll be a moment in time after her aspiration that you could sample her blood and see a low neutrophil count. And that's not because she doesn't have inflammation. It's because she does have intense acute inflammation, and those neutrophils are leaving circulation and heading into the tissues. Well, we actually have a storage pool of mature segmented neutrophils in the bone marrow waiting to replace those, right? Our mammals do. So we replace those, and so then those come out of the bone marrow fairly quickly. So there's another time point, if you check my dog's blood in the face of this aspiration pneumonia, that she has a normal neutrophil count, and they appear mature and segmented, because we just replace that circulating pool of neutrophils, right, with this storage pool of mature neutrophils. So we, in this case, would check her blood, her CBC would look normal, and her scattergram would even look normal at this point, and not because she doesn't have intense inflammatory disease. Now, those neutrophils that came out into circulation from the marrow, those are also going to head into the lungs, right? Because this infection's not done, right? So the inflammatory cytokines are still high. The cells are going to leave the blood again, enter the tissue. But she doesn't get a neutropenia again, because now the bone marrow is going to start spitting out younger cells, younger neutrophils, to try to meet this demand. It's trying to mature them more quickly through the bone marrow and still spits them out when they're too young. So we start to see bands, maybe even metamyelocytes. And so when we can capture those in circulation, when we can identify those bands in circulation, that tells us, no matter what the whole cell counts are, that we have intense or overwhelming inflammation, such that the mature neutrophils, the 10,000 that were there in health, were not enough to fight off the inflammation or infection. The 10,000 more that came from the bone marrow to replace those were not enough to fight the infection. Now we're starting to release the young ones, because we're losing the battle, right, against that inflammation. And so in her dot plot, recognizing that the neutrophil cloud is moving higher up on that y-axis because there's neutrophil cells, right, that are higher, that are larger, because they're younger cells are larger. That's where we recognize the bands. That's where we've captured them objectively. And we can look at them relative to a normal, healthy dog and recognize that left shift, which tells us we have intense or overwhelming inflammation, right? Which is the crux in her case, is trying to answer Dad's question of, do we need to intervene further? And that alone tells us we need to do something different, because she's losing this battle right now, right? Against with this inflammation, she is mounting a more left shifted, right, response because the mature neutrophils were not enough to treat it.
That's great. And we do have a little bit more of a straightforward story on our chemistry panel, obviously, right? So when we shift over to that chemistry, we can see that Blondie has low sodium, low potassium, and chloride. We know, of course, that chronic vomiting in dogs leads to significantly decreased electrolytes. That persistent vomiting removes the essential minerals, leading to imbalances that we're seeing here. That not unexpected, right? And given her history and that severe dehydration that she's experiencing.
Right. And it may be that we're also getting fluid shifts into the gut itself, right? It might not be all lost from the body, right? Which, if it was selective chloride, I'd be even more concerned with. It was truly exclusively through vomiting. But I do wonder if she's getting some effusion of fluid into the gut itself, or even potentially into the abdomen, right? If there were a perforation or other compromise. But I would totally agree.
Very, very good point. And then getting back to the owner's number one concern here, are we headed for surgery or not? Turns out even the veterinarian in this case is a little bit on the fence. And so these abdominal radiographs that we get on Blondie is where our uncertainty is sort of creeping up on us even more, right?
I was just going to add that I think the lab work, it facilitated communication, right, with a pet owner to then say, we start with just a CBC, right? That's an easy thing as far as our diagnostic journey to have a great assessment of how sick is our patient, right? So they start with that and communicate that I recognize in the scattergram, I know the numbers look okay, but in the scattergram, I see this left shift. That has me concerned, right? That she's dealing with this more intense inflammation, which when dad recognized that as well, right, we actually like to show them the data when we can, show them that value of that CBC and the technology that the HT5 has to help us identify those bands through the scattergram. It was then that we said, well, let's see if the rest of her body looks sick, right? How's our organ function, et cetera. And so that prompted the chemistry as the next test. And then to answer dad's question, then we say, well, yes, we do think there is a concern from what she ingested. Right. So whether or not that, and we haven't even ruled out that this could be a pancreatitis or something, right? She had new treats as well, other, gastroenteritis, but showing dad that, yes, we've identified significant inflammation. We have fluid shifts, I think, resulting in those electrolyte changes, meaning both through her vomiting and maybe into the gut as well, that prompted, I think we're going to have to make the next investment, and that's going to be on the radiographs, right? Because now we're actually looking, do we see an obstructive pattern? Do we have a reason to say we have to cut? Because that still is the voice of this client, right? Saying, do we have to go to surgery? So we're looking for layers of support, right? This clinician is.
Right. And those findings in a linear foreign body can be subtle, right? Depending on the timing, the degree of plication of the intestines is highly variable. We want to hopefully see those gas pockets trapped between the folded loops of bowel, but once again, those gas patterns can be nonspecific. As you mentioned, we have other differentials that look a lot like a foreign body, including enteritis or ileus. And just the fact that foreign material is radiolucent, right? So if it's string, if it's fabric, we're really not going to see something that's radio opaque here that's glaring at us, right? Unlike a metal foreign body or something like that. So we have a lot of different variables that come into play here that make this diagnosis a little bit more difficult to interpret on radiographs. So for all of the reasons that we just kind of went through, this veterinarian is at an impasse here and not really sure what to do. So Holly, what are the options that this veterinarian discussed with the owner at this point?
Yeah. So, and again, every situation will be contextualized to that specific pet, to that pet parent, right? What their concerns are and what questions we're trying to answer. And so to be able to get more ammunition to better understand whether it's surgery or no surgery in this case, the clinician offered two options. And one was to get a more objective assessment of that inflammatory process. So, there's still an art to looking at those dot plots and the scattergrams, and it doesn't give us a number on that inflammation. It just gives a more subjective evaluation of them relative to a healthy patient. And so they offered looking at C-reactive protein, an acute phase protein that we look at in dogs that tells us, and it measures the systemic inflammatory process. So I think this is way underutilized in practice. We run a CBC to look for inflammation all the time. We do things on our physical exam, take a temperature, a palpation to assess for inflammation, but getting a more objective assessment through looking at acute phase proteins is really powerful, because when you have a major acute phase protein, like looking at CRP in dogs, the baseline value, it's not stored. So a baseline CRP in a healthy dog, will be minimal, minimally detected. And then what happens in response to systemic inflammatory processes? So not any inflammation, not a bruising, not, even sometimes fractures don't necessarily create a systemic inflammatory process, right? When I talk about that, I mean things that cause fever, right? So think of different illnesses. Think of when a patient would present with a fever. Those are systemic inflammatory processes. They're commonly related to bacterial infections, but severe pancreatitis, fulminant autoimmune disease, right? Those all stay on the list. And again, I think our veterinary teams relate most to thinking of things that create fever. That allows us to encompass most of the systemic inflammatory processes. And so in this case, looking at CRP, it rises within hours of the inflammatory process starting. And then it will also, as it resolves, it starts decreasing within hours. And so you don't have the lag that we have in our leukocytes in their response to inflammation, or the lag in their recovery. Think of those pyometers that you take to surgery, right? They come in with a high leukocyte count already, a high neutrophil count. You fix the problem in surgery, but tomorrow their neutrophil count is twice as high. And not because they're any more sick, right? You've actually fixed the problem, but you stop the egress of those neutrophils into that infected uterus. And so they're backed up in the blood for a little bit until the bone marrow quiets down, right? So those changes can lag, but the acute phase proteins really change very in time, within hours, and it gives us a numerical evaluation to look at. So in this case, she said, well, I'm trying to figure out how sick Blondie is, and I see that the dot plot suggests to me that there are bands, but can I quantitate that? And that would be a useful tool. And we have options on the Element I Plus to run the CRP in practice, right? So we can do that in clinic and get those results back within minutes. And so they did run the CRP on Blondie, and it came back at 14 mg per deciliter. Yeah, really high, right? So 0 to 1 is what we see in health. 1 to 3, maybe 1 to 5, we're in a gray zone. Maybe it's starting to mount, maybe it's starting to recover. But, we get over 10 mg per deciliter. This is pretty severe systemic inflammation. And gut compromise and GI flora being somewhere it shouldn't be is top on my differential list, even if she wasn't presenting with these clinical signs, right? We think about all those gram-negative bacteria. Yep, exactly. I worry that there's some perforation, some compromise that's allowed the body to see these systemically outside of the gut, creating that really high CRP. So then they, again said, now I'm more concerned looking at these radiographs, right? And I see these gas patterns, and they actually did a repeat of those radiographs at a 4-hour mark. Again, trying to make this big decision, right? Whether or not to go to surgery, because Dad is hoping not, right? Repeatedly hoping not, unless she has to, is what Dad says. And the gas patterns, they move some. So it wasn't, again, a slam dunk that there was an overt obstructive disease. And so that's when we leverage some tools to bring expertise into the practice. So why don't you talk to us just a bit about rapid read, which is what she enlisted here.
Yeah. So once again, artificial intelligence or AI-based diagnostics are sort of like the rest of the world, something that we're now something that is newly available to us in veterinary medicine. That many of us, I graduated 10 years ago, and we certainly were not talking about AI-based tools a decade ago. So it's a pretty common conversation that I'm having as a senior professional services veterinarian with veterinarians who are, especially those that have who are like me, who didn't learn about this in vet school. They're a little bit hesitant, but I think what we want to remind everyone who's listening to this is that Rapid Read is an AI radiology tool that was entirely trained by board certified radiologists using a very robust data set, right? And so the findings that we're concerned about here in the abdomen as it pertains to a potential foreign body, that is one of the the differentials that rapid read is very good at assisting veterinarians in interpretation on. So in this case, we're not using rapid read to replace the clinical decision the clinical decision making skills of the veterinarian. That is never the intention, but to complement your clinical decision making interpretation of this particular set of images, right? And so in this case, the veterinarian did opt to send these radiographs off for a rapid read interpretation. And as we see on the report that comes back, rapid read did flag obstruction and plication. And because this is potentially life threatening, because this is the type of finding that would warrant surgery, I think it's important to note that cases like this are escalated for a stat review by a board certified radiologist. And certainly enough, the radiologist confirmed that this is absolutely a candidate for surgical intervention.
And that was just the confidence, right, that this clinician needed, was getting that expert feedback and having that delivered to her in the practice, right, is so cool. That the quick access to the rapid read, which comes back, I think, within 10 minutes, comes back within minutes. And then it said, because this is a life-altering finding, right, it'll be forwarded and you'll get a stat radiologist review. So they waited on that. Indeed, again, Dad's hoping to not go to surgery, but indeed it came back confirming that linear foreign body, right, with a plicated appearance, and did say, yes, consider surgical intervention. And again, go back to Dad with the power of that expertise delivered at the practice setting in an emergency case like this was everything that gave the confidence to the clinician and the owner to collectively make the decision to take her to surgery. And in talking to this clinician about the case, I think she also felt the detailed report from the radiologist was super helpful to have her understand what she's expecting to see when she goes in surgically, right? Make sure she's not missing something that they're seeing, and that she would continue to run the bowel to find it if not, right? But again, delivering that expertise to support this solo practitioner on a now Saturday evening when she's going in for this exploratory, right, to know what she should be looking to find. And as you have probably seen, that surgical report is pretty extensive.
It's extensive, and clearly we had to have a pretty intensive procedure done with removal of a large section of bowel, because surgery showed this linear foreign body that was anchored from the stomach all the way down to the jejunum. We did have plication in there, as we would expect with a linear foreign body. And as you were saying, with all these, with this band neutrophilia left shift, we had perforation, as you feared. And not only that, but some large sections of bowel that were ischemic, right? So that dark bluish or that dark purplish black coloration that nobody wants to see when they go in for an exploratory. It was screaming at us.
Yeah, and I think that these cases are challenging for our GPs in surgery, probably for all surgeons, but they have to make some in-time decisions when they're in there, right? As far as what bowel is pinking up, what should stay, what is disease, what needs to go. And I think that historically, before some more advanced diagnostics, we would sew these dogs up and then we would just keep our fingers crossed. Right? It would be a mystery of how things are repairing in there. And we are lucky then, having invested in the CBC with the detailed cytograms, having invested in the CRP so we can quantitate what she looks like going into surgery, we then can sensitively trend those post-operatively so it's not a mystery of what's going on in our abdomen, right? So we can ensure that we are not getting an early look at a complication developing of an area dehyst, or there was an area that was more devitalized than they realized at surgery and they left in, is that it doesn't have to be a mystery, right? And again, that early investment in those diagnostics means we can reap even more value, right, in repeating them. And that's what they did over the next 2 days, was trending that scattergram, right? The whole numbers will not tell the whole story in that CBC, right, because of those neutrophil dynamics. But the scattergram will tell the truth, right? It'll show you how many bands you still have, right? You can look at that graphical depiction and compare it over the days. And we saw that those larger events of that turquoise cloud of neutrophils settled down back to where they should be over the next 2 days. They became more mature, which meant we were getting a toehold on that inflammatory process, not as left shifted. And then again, that objective assessment using that CRP, because it will come down, right, in tune with the inflammation resolving. And it did continue to drop over the subsequent 2 days. And And using these diagnostics tools allows us to, again, contextualize Blondie's care and being particular to this owner and his concern, which was getting her home as soon as possible. As soon as we felt she was clear out of the woods, reducing the cost and the days of hospitalization and them being apart, because he was pretty emotional, right, about this whole thing of her going to surgery and being hospitalized. But watching these over these 2 additional data points to see that everything's trending the right way gave additional confidence to the clinician to say, everything seems to be going the right way. I think surgery was a great success. We will send her home to recover the rest on her own.
Right. And, this is a really elegant case, in my opinion, in terms of being able to really see the value of these, of being able to leverage the diagnostics that you have available to you, that so many veterinarians don't even realize that they have that information available patient side. I would say, clearly, it's more common than not for me to have a conversation with veterinarians, and they oftentimes disregard the scattergram or the dot plot altogether because they don't really understand how to interpret that. And depending on what analyzer they used historically, they may not have that information available to them in the way that we have it available to them on the HT5 and also the HT5 plus, right? So there's that piece of it. And then I also would say, Holly, that it's more common than not that veterinarians are not using CRP at all, and I think that's an interesting conversation to have on the side, probably bigger than the scope of this conversation. But why is it that veterinarians in the United States are not as familiar with using CRP? And as we've illustrated, not only did this help move us in the direction of understanding that surgery was very likely warranted here, but it was also imperative in the aftermath of the surgery to be able to feel confident that our surgical intervention was successful.
Correct. Yeah. And I think that her case also highlights, right, the importance of these diagnostics and digging in deeper when maybe superficially they don't align with what we're seeing clinically. Right, that exactly. As you said, normal CBC, right? Because the patient's value fall within the reference interval. It doesn't tell the whole story. And I love the phrase, correct, absence of evidence is not evidence of absence. That is great. Yes. I think that's brilliant. And especially when it comes to detecting inflammatory disease. This has been very eye-opening in my position where I consult at a hospital for the past 12 years or so, was recognizing what we read in the books is not always how it plays out in our patients. And this absence of the classic inflammatory leukogram, I think, really trips people up because they know they have a case with inflammation, and yet they don't see it in the whole numbers. And that's where those cytograms become so important. Recognizing that stress leukogram, right? That might be the first thing that flags low the lymphocytes and the eosinophils to let you know this is a sick patient, right? Especially Blondie was presenting with vomiting and lethargy, but sometimes it's an ADR patient, ain't doing right. Right? And we don't know if it's a behavioral change, like why did they skip the meal? And recognizing that stress response as an indicator that you have a sick patient can be really an important tool to use. And that, having the objective data inform the conversations with the pet owner. Right. I think that takes a lot of pressure off of the clinician, right? But informs that collective conversation, right, with our pet owner. And when we do them, we maximize our point of care tools. We're able to have those conversations in time while we're showing them results. They're able to show them the concern on the scattergram. They're able to show them the CRP results, able to show them the rapid read report, right? And hold on till we're going to get an overread by a radiologist. And I think in those cases, our diagnostics were able to really show the value in our communication with the pet owner. And again, to make the most informed collective decisions with them.
Right, because everybody can relate to that veterinarian who is facing that indecision as to whether or not we go to surgery or not. Obviously, with not just the health of the patient, but obviously, we also don't want to be on the other side of that where we go to surgery and didn't find anything. We've all been there as well. But either way, we have so much more power in making that decision when we layer together all these different diagnostic options that are in the portfolio, right? So moving beyond the CBC and chemistry to also encompass CRP as a patient side piece of data that we perhaps are not leveraging, and I would say not perhaps, but we are certainly not leveraging enough in the United States and Canada at least. Bringing in imaging, and then of course when that's not sufficient, also being able to leverage AIS services, including rapid read. to make sure that we have the full clinical picture and make a confident decision to move forward with surgery here. And so, better patient outcomes are going to happen when we have all of these diagnostic tools available to us. Ollie, thank you very much for bringing this case to our podcast today, because I think this is going to be a game changer, especially in helping veterinarians take a closer look at those scattergrams or dot plots on the HT5 or the HT5 plus, as well as CRP on the Element I plus, and then of course remembering that we have rapid read available now and AIS services for that image interpretation power that so many veterinarians are grateful that they can rely on that as well. So altogether, I think this case shows how layering all these diagnostics can bring clarity to even the most uncertain cases. And like I said, at the end of the day, this is about life-saving decisions, and we all want to make sure that we have all of the diagnostics available to us to make sure that is the outcome that we get whenever possible. So thank you for bringing the case to us, and thank you all for listening and for joining us on Tales from the Lab. We'll see you next time.
Listen to new episodes of Tales from the Lab wherever you get your podcasts. And now you can also watch us on YouTube and Spotify.
Be sure to like and subscribe for exciting new content. Share new episodes with your colleagues and follow us on Instagram at Tales from the Lab. That's TAILS from the Lab. We're grateful you're here.